Well, good afternoon. We're going to kick off this session, this first abstract session. So I'd like to introduce my co-moderator, Dr. Kikuchi Kieta from Tokyo, Japan.
Yeah.
And I'll introduce our first speaker, Alexander Docolari, who will be talking about risk scores that can predict long-term survival and MACE after coronary artery bypass grafting.
Hello, everyone. My name is Alexander Docolari, and I'm going to present the risk score to predict long-term survival and MACE after CABG. I have no financial disclosure. Some advertisement. Lankenau Heart Institute is a 3 STS program in transcatheter valve and CABG, and there are 6 attendings. So there are nearly 800,000 patients all around the world that every year undergo CABG. And we have good scores, like the STS and Euroscore for 30-day all-cause mortality. However, sometimes they tend to overestimate the risk, and this is published in literature already. But there is no single coronary only for CABG. Like for now, for example, now there is a 3 score for valves. But for CABG, specifically, there is nothing. Moreover, there is no risk score that is good to understand long-term outcomes after CABG. So, as I mentioned, these are the 2 main problems. So we don't have a specific risk score, while only for CABG, and no risk score for long-term outcomes. So the only risk score that was done in 2012 has a big problem. It is not externally validated and calculates only survival. It doesn't calculate MACE. But why do we need MACE? So we need first a reliable CABG score, a score designed specifically for CABG, a score for long-term survival and MACE, and this is externally validated. So the primary objective was to develop a risk score for all-cause death and MACE, and we use the lasso method to calculate the score. So these are the preoperative data of the patients. The risk for models for all-cause mortality was age, BMI, renal function, creatinine clearance, dialysis, COPD, diabetes, and history of atrial fibrillation. Risk for MACE was age, renal function, creatinine, PVD, prior MI, black race, and history of atrial fibrillation. Internal cross-validation at 1 year showed an AUC of between 71 and 73% for MACE and 79 to 80% for all-cause mortality. And these are the lasso curves for all-cause mortality, and this is for MACE. And this is the table how to calculate the risk score for long-term outcomes on the left and from here and for MACE on the right. We did also an external validation of 655 patients from the University of Brescia in Italy. And these are the AUCs for the external validation of the score. All of them are above 65% for all-cause mortality and MACE. So problem number 2, why do we need a risk score for long-term CABG? Well, should the cardiologists think about the follow-up, not the cardiac surgeons? So the current clinical trials provide data on patient survival and MACE. However, they are discordant based on patient comorbidities. In addition, trials are not fitted to selective patient risk. A patient that has a high risk score and has a stroke, he would, in the future, he would like to know that he may have a stroke, because life with a stroke is not a pleasant life. And in addition, if you tell to the patients, in 5 years, your stroke rate or your MI rate will be this, then there is more surgeon-patient relationship increasing based on fairness. So in conclusion, we provide a new risk score with external validation to assess long-term mortality and MACE after CABG. The score includes race and is a good match among observed and predicted outcomes. Thank you.
Thank you very much for an outstanding presentation. Any questions from the floor? Well, if that's not the case, you actually answered this a little bit in your last line, was that your AUC is in the 65 to 70%. That's better than chance, obviously. How does that compare to the STS Prom or Euroscore 2 in terms of, is that, I must say I don't know the actual data in terms of AUCs for those scores.
The thing is that Euroscore 2 and STS score are only for 30-day all-cause. This is only for long-term outcomes. So it's difficult to make a comparison like STS versus this. However, I must say something. Euroscore 2, when it was built originally, it took patients with mitral valve, patients with tricuspid valve, patients with aortic valve, CABG, mix them all together and see what comes out. And this is not fair, I think, right?
Absolutely. Now, so I believe in Lankenau you have quite a specific way of taking care of patients. You have a very active robotic program, minimally invasive, and so on. You looked at an external data set. Are you going to try and validate this externally further?
Yes, we'll do, for sure. For sure, we'll do with other data sets. For the next presentation, if you don't mind, I would like to invite Dr. Torregrossa and present it, if you want.
You're the best.
Okay. Okay.
Okay, so you get to continue then.
Okay.
Could we have the next slides?
Okay. But no, okay, we'll see here because it's not here. So, long-term outcomes of robotic as CABG. I have no financial disclosure. Again, some advertisement for Lankenau Heart Center. I love that center, sorry about that. So, there are some 4 common beliefs. Robotic-assisted CABG is difficult to master and there's a steep learning curve. The second one is, why do we need hybrid CABG? What's the logic behind it? The third one is often a single institution, like only Lankenau. Like no other center does that. How can we say it's good? And robotic CABG costs much higher than traditional CABG. And it is difficult and impractical to build a team for robotic-assisted CABG. How do you get cardiologists on the team? It's a common belief. Mastering the robotic-assisted CABG, our experience. So first of all, not every single patient undergo robotic-assisted CABG. There are patients undergoing traditional CABG are not candidate for robotic-assisted CABG. This type of patients who undergo robotic-assisted CABG are mainly candidate for PCI. So what we offer is a traditional Lima to LAD, which is the gold standard, on these patients, and not PCI on the LAD. So with Dr. Torregrossa, we do have a 15 years clinical experience with the whole robotic CABG, and we divided it into 3 different periods to understand how things go. And we did match them with a propensity-adjusted analysis. Just to say, it's not propensity matched, it's propensity adjusted, which adjusts post-operative outcomes, not preoperative outcomes like the propensity match. So these are the preoperative data with a mean age of 65 to 68-year-old and an STS prom of 0.9. Post-operatively, there was a decrease in the time in the OR, decrease in total length of stay, hospital length of stay, a decrease in platelet unit transfusion, and decrease in prolonged ventilation in hours. On the long-term data, there was also all-cause death, MACE, stroke, MI, and repeat vascularization with stent decreased from the first to the last period. These are the Kaplan-Meier survival curve, and the study was published on aero intervention. Common belief 2, what is the logic behind the PCI? Is it safe? So we did a stage hybrid robotic revascularization, which means CABG followed by PCI within 30 days. This is what hybrid consists in. These are the long-term outcomes. At 12 years, all-cause mortality was 75%. So we want more granular and see how many of these patients had repeat interventions with stents. From 800 patients, more than 800 patients that underwent ongoing hybrid, only 139 had repeat intervention with stent, of the whom with new vessel disease was 73.4%. And graft failure, only 20 patients. But this 14.4% is from the 139, not from the total 800. In that case, it would be like 0.1%. Common belief 3, robotic CABG is often a single institution experience. It's not. Emory published its own data, and we have similar outcomes as Emory does. Well, compared to other institution, hybrid, we can see our data is even better. With HCR in the New York State is similar or even better. Nonetheless, our age population was 6 years older than the HCR from New York State. The same thing for repeat revascularization. Common belief 4, robotic-assisted CABG has higher costs compared to traditional CABG. Well, it's not. We published those data, and it's around $3.2 million less robotic-assisted CABG as compared to traditional CABG. This includes the cost of the robot, all the other adjunctive costs, including PCI, repeat readmission, and everything else. What causes the difference is the hospital length of stay. And this is what I told to the Cardiovascular Business Journal and to the Cardiology magazine, which is official American College of Cardiology magazine. Common belief 5, it is difficult and impractical to build a robot team for robotic-assisted CABG. Well, it's not. Dr. Torregrossa already published those. And it needs a leadership for that, and to have the cardiologists on board for that. So in conclusion, overall, reduced incidence of following outcomes was seen between the 3 time periods in terms of OR time, all-cause mortality, MACE, stroke, MI, and repeat revascularization, while PCI in hybrid was 73.4% for new vessel disease. Still not convinced? Okay, maybe a clinical trial will do, all but gold, traditional CABG. However, I stole this from Dr. Torregrossa, this slide. We are ready to adapt. As you see, the Nokia CEO said, we did everything right. We did not do anything wrong, but we failed. Thank you. Five versus 7 days.
On average, I would say, great presentation, great job. No, I think this one, great job, great presentation. On average, I would say our patient stays 4 days for a robo, even less than that. We are trying to decrease the length of stays of robotic. Like we have 100% extubation on the table of robotic. Of course, it's selected patient. Again, the message that was well delivered here is that robotic CABG is not here to take the job of sternotomy. There will be always patients that cannot be candidates for robotic CABG. But here is to take patients that get multivessel PCI or patients too fragile to receive a sternotomy and that could be treated with an hybrid intervention in a different way. Grandpa, 85 years old, maybe he shouldn't have 7 bypass open on a cardiopulmonary bypass. We can give him 1 or 2 mammary arteries robotically and stent and whatever is the rest. The concept of full revascularization has a different type of value in different age or in different patient risk population.
Any question from audience? I have a question.
Please.
Okay. Congratulations. And can you tell me what the percentage of the complete revascularization when you do the hybrid, robotic hybrid?
Yeah, so if you look our series, in general, we have around the total robotic cases, we have 17% of reverse hybrid. These one are patients that comes in the middle of the night with a STEMI. They get a stent into a non-LAD target that is the culprit lesion, but they have significant LAD disease, and the patient gets referred to us to receive a robotic lima to LAD. So you do the robotic lima after the stent is placed. We have around, for the rest, we have around 45-50% of hybrid, and the remnants are isolated LAD or BIMA. This is
Yeah,
more or less.
because you know, if patient have a triple class disease and put rheumatoid LAD with the Da Vinci, after then, if the patient have a disappeared symptom, it goes to optimal medical therapy, isn't it?
It's a good concept. So we have seen sometimes, particularly in elderly patients, they come with, I don't know, a right and an LAD. We do the lima to LAD, and even in agreement with the cardiologist, we just don't stent immediately the right. We might do some imaging or stress test at 3 or 6 months. If the stress test is positive, we treat. Otherwise, we treat it as a medical, like optimized medical therapy.
Okay.
I think this is an area where the hybrid trial, which John Puskas and Greg Stone tried to conduct a few years ago, they weren't able to recruit enough patients because cardiologists did not buy into it. It sounds like we've got more and more momentum, and we're talking so much more about hybrid revascularization that it may be the right moment to do that now.
I completely agree, and echoes your feelings. I think that we came out too early with the NIH trial of hybrid. It's time to revamp it. It's time to reconsider it. Absolutely. Great job, Alex.
Thank you.
Dr. Mikhail Fomenko.
So we have a presentation on T-graphs, but I don't believe the presentation has been uploaded. So is Dr. Fomenko in the room by any chance?
No?
No.
Okay.
Okay.
So next speaker is Dr. Marco Gemeri, heart rate rotate, exploring the impact of preoperative atrial fibrillation on outcome in off-pump CABG. Please.
And actually, it'll be Ettorino Di Tommaso who's presenting.
Hello, everyone. Thank you for having me today. It's an honor for me to present. So my presentation is about the impact of preoperative atrial fibrillation in patients undergoing off-pump coronary artery bypass grafting. So as we know, atrial fibrillation is the most common abnormal cardiac arrhythmia, and its incidence tends to increase in patients with age, and up to 50% of patients older than 80 years old have atrial fibrillation. Nowadays, the demographic of our cardiac surgery patients have significantly changed, with patients being older, more frail, and with comorbidities, and these are all also risk factors for atrial fibrillation. And this topic is obviously well been treated already in literature, as for example with this quite recent meta-analysis by Dr. Saxena in Australia, underlying how preoperative atrial fibrillation portends for poor outcomes after coronary bypass surgery. So in our study, our aim was to investigate the effect of preoperative atrial fibrillation on in-hospital outcomes and survival in patients undergoing off-pump coronary artery bypass surgery. We, as a group in Bristol, we retrospectively analyzed data for patients undergoing coronary artery bypass grafting in a period of time of 20 years. And during this time, over 7,000 patients underwent off-pump coronary surgery. This is mostly because half of our consultant team in Bristol, they prefer off-pump technique as a primary treatment for CABG. Out of these 7,000 patients, 306 patients we had preoperative atrial fibrillation, and we investigated as a primary endpoint in hospital mortality and long-term survival. As a secondary endpoint, we looked into postoperative complication and length of hospital stay. We also ran a regressive model adjusting for baseline characteristic in order to analyze the survival in the long term. So these were our patient preoperative characteristics. As we can see, there were no major differences apart from the age and less incidence of female sex in patients with preoperative AF. Otherwise, there were no great differences in preoperative eGFR, preoperative CVA, LVAF, and urgency of the operation. Our results show that patients with preoperative atrial fibrillation undergoing off-pump coronary bypass surgery had a higher incidence of dialysis post-op. They tend to be in hospital longer, and the in-hospital mortality was also worse. On top of this, in terms of survival, we ran a regressive model adjusting for baseline characteristics, and this clearly showing in our study that the pre-op atrial fibrillation is an independent risk factor for poor survival after off-pump surgery. This is our long-term survival curve. We had a median follow-up of 10.7 years, and as we can see, there is a clear difference between the survival of patients with non-AF and patients with preoperative AF in the long term. So, in conclusion, what we can say is definitely pre-op AF is a risk factor for poor outcomes following off-pump surgery. Most of all, the pre-op AF is an independent risk factor for poor survival after off-pump surgery. This is likely related to the fact that patients with preoperative AF, they tend to have more VT, they have more incidence of cardiomyopathy and also congestive heart failure in the postoperative course. And this actually is, this study, I think, is highlighting how important it is to improve the management of atrial fibrillation in patients undergoing surgery, in particular CABG, either in the preoperative time, intraoperatively, and also postoperatively. That should be our aim in the future. Thank you.
Hello. Nice talk. Kurt Wozniak, San Francisco. To your last point, did you guys report on ligating the appendage or epicardial ablation or?
So we didn't. That's definitely something that we need to look into it. The data set is covering a period of time of 20 years when I think left atrial appendage wasn't really a big thing a long time ago. We start doing it more routinarily in Bristol now, and so that's something that obviously in the long term we need to look into it. Absolutely.
Thanks.
Great presentation. In 2009, we published the STS data on that, and we actually led the inclusion of AFib into the risk model of CABG in the STS model. And we found kind of the same things, you know, in so on and so forth. The one interesting finding we had that overall there is an importance of AFib on patients, preoperative AFib on patients. But the relative impact is higher in patients that are healthier with normal EF. Did you check it by EF? In other words, the logic behind it, the way we could explain it is that when you have renal failure, low cardiac output, blah, 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 all those other things, AFib is part of the package deal, so to speak. But when you have someone with normal EF and AFib, it's really something that you should be worried about.
Yes.
Did you look by EF?
We didn't, but actually, well, from this data that I shown, I think it's we were a little bit surprised that the baseline characteristics between the two groups were not so like we were expecting patients with preoperative AF to being worse. Instead, they were not, and despite this, they were not doing well. So I think what we should look into it is find out where the AF impact in patients who don't have such so bad baseline characteristics. So that's something that we should.
Do I have time for one more?
Go right ahead.
So the other point is you may have, I don't know what was the Euroscore 2 on those patients, the average, but maybe you pre-selected those off-pump cases to be higher risk patients for CABG on pump. I don't know the practice. So it basically takes this factor away from differences between the AFib and non-AFib.
We in this specific study, we didn't sub-select in a sense that because it's so common practice to do off-pump, there is no such thing like bringing only high-risk patients for off-pump surgery. We also do routinarily off-pump in any class of patients. But the Euroscore, I didn't show it, but in this specific study, there were no major differences between the two groups in the Euroscore 2, which, as we know, is quite poor in terms of predicting at the end.
Well, thank you very much.
Thank you.
Move on to the next paper.
Thank you.
So our next paper will be presented by Marco Gemelli, looking at off versus on pump CABG.
Hello to everyone. It's a pleasure to be here to speak. So I'm going to present another analysis of the databases just presented by my colleague. It's a comprehensive analysis of this database comparing off-pump versus on-pump CABG outcomes in Bristol in a high-volume CABG center. So basically, as we all know, safety and long-term outcome of off-pump CABG has been studied over the last 25 years. Data from large database have suggested superiority of pump CABG in the early in-hospital outcome, but there are less data and not shared data on long-term outcomes of pump CABG. Of course, one of the key predictor of early and late health outcome of the patient is surgeon personal experience and expertise. So these are all many studies that have been published in the last year, also in very important journal like New England Journal of Medicine. And what we did is that we have an institution where we have 4 very experienced surgeons in off-pump surgery and other 4 surgeons who predominantly perform on-pump CABG. And we went to compare the outcome of the 2 populations. So the aim of this study was to compare the short-term outcomes and the long-term survival of these 2 groups of patients. All consecutive patients undergoing isolated CABG in a 21-year period were individualized, and we collect all the preoperative, intraoperative, early postoperative, and outcome data of this patient, and also the long-term survival of this patient. So we had more than 3,000 CABG with a mean of more than 600 CABG per year, and 45% of these CABG were done on pump, while 55% of these CABG were done with an off-pump technique. So these are the preoperative characteristics data. As we can notice, basically, off-pump patients tend to be a little bit younger with a higher BMI, and there are less women in this population. And also, they tend to be with a lower rate in sinus rhythm. According to the intraoperative characteristic, we can see that the number of these vessels is pretty the same between the population, like the number of patients with a critical left main involvement, while the number of grafts is slightly less in the off-pump population, of course, with a mean which is 2.5 versus 2.9, and a median which is the same for the 2 populations. According to the postoperative outcome, we have that off-pump patient had a lower in-hospital mortality, a shorter length of stay, a lower rate of return to OR due to bleeding, and a lower rate of postoperative cerebrovascular accident. And also there was a trend toward a lower incidence of postoperative dialysis. So we ran also a logistic regression for in-hospital mortality, and we found that on-pump CABG was an independent predictor of in-hospital mortality. According to the long-term survival, we had a mean follow-up of almost 10 years, and we can see that basically on-pump CABG resulted to be a risk factor for increased long-term mortality, but only in an unadjusted Cox regression, while when we ran an adjustment for all the comorbidities and the confounder, we found that the two procedures were comparable in a long-term period. We also have run 3 small subgroup analyses of 3 different populations. The first one is about older patients, so older than 75-year-old, and we found basically that in terms of postoperative outcomes, the postoperative outcomes were similar, apart from the postoperative cerebrovascular accident, which were more common in the on-pump CABG. Also, the long-term survival was pretty similar, and there was no significant predictor of long-term mortality between the 2 procedures. The same resulted for patients with a prior cerebrovascular accident. Of course, the only thing that was evident and statistically relevant was that the patient done through an off-pump procedure tend to have less postoperative cerebrovascular accident. And in terms of long-term mortality, there was no difference. The most interesting thing is that when we analyzed the third and the last subgroup, the patient with severe chronic kidney disease, we found that the in-hospital mortality was significantly higher in patients who underwent a non-pump CABG, and also the long-term mortality was significantly higher in patients who underwent a non-pump CABG. And we found that on-pump CABG was an independent risk factor for increased long-term mortality for patients with chronic kidney disease. So in our experience, we can say that off-pump CABG in experienced hands reduced the incidence of perioperative mortality, CVA, reopening for bleeding, length of hospital stay with better long-term survival. Off-pump CABG is also not a predictor of higher long-term mortality in our series and is associated with a markedly superior long-term survival in patients with CKD. Thank you very much.
Thank you very much. Any questions from the floor?
I think, Marco, great presentation, really fantastic. It's nice to see that there are some young surgeons that are still promoting the concept of off-pump. Off-pump has been really brutalized, I would say, and the data, and I think the common belief is that it's not safe, it's not good, and we shouldn't adopt it. For sure, require a mastering curve, but the data support the evidence that effectively safe. I was always been interested about stroke. I could have never understood why off-pump in a major, larger randomized trial never proved superiority respect of on-pump. And I think mostly has to do with a side-biting clamp. How do you perform, or how the surgeon in Bristol perform proximal anastomosis? Do they use a device? Do they side clamp? What is the preference? What was your aortic rate in those series of off-pump?
Yeah, so honestly, in Bristol, they are quite old school in this term, so they do off-pump, but they do the proximal anastomosis with a side clamp. So there is a clamping of the aorta. It's not totally no aortic touch.
Can I ask you?
Yeah.
Did you check the graft flow during surgery?
Excuse me?
Did you check the graft flow? Do you use
No.
transit time from?
No, they do not have the machine in Bristol, so basically they do not check the flow, which is a pity because it would be great.
Do you have any difference using multi-arterial grafting between off-pump and on-pump group?
So we checked this I didn't show the data, we checked this. In Bristol, they mostly do limon LAD and vein for the other target. Not all of patient, but most of the patient. We check if there was any difference in the rate of arterial graft between on-pump and off-pump, and there was no difference. The P was more than 0.8, so no difference at all. But honestly, there are for most of the patient, veins are used.
Are the same surgeons?
No, so in Bristol there are 4 surgeons who mainly do off-pump, and basically there is no selection of patient for these 4 surgeons. There are 8 surgeons in total. The other 4 surgeons do mainly on-pump.
Any difference in their experience?
So in terms of CABG, basically these 4 surgeons specialize in off-pump surgery, but in terms of year of experience, the seniority is very similar between the surgeons.
Maybe just one comment from methodologies. You've got a fantastic number of patients, but you see that your baseline characteristics are different between groups. From what I understand, you didn't do any propensity score matching.
We have already working to do this for publish the article.
Especially if your conclusion is that off-pump reduced adverse events. That's causal language, and you can't do that in observational studies.
No, for the number of patients, we want to do that.
Other than that, very small remark. Thank you very much.
Thank you.
Outstanding presentation.
Okay, next speaker is the outcome of pulmonary vein ablation RCT on comparing preventive strategies for the new onset POAF in CABG. Dr. Emiran B. Vale.
Thank you. Good afternoon, dear colleagues, dear chairman. Thank you for the opportunity to present our study. No disclosures. Postoperative new onset atrial fibrillation is the irrelevant impact of early and late mortality and morbidity. Myocardial ischemia is one of the most important triggers of AFib. Perioperative amiodarone administration is not quite effective for prevention of the atrial fibrillation. Some studies concluded that pulmonary vein isolation does not decrease the incidence of POF also. That is why we have designed a single-center prospective randomized clinical trial, follow-up, intended to evaluate of PVI on prophylaxis of postoperative atrial fibrillation after CABG. Here is an inclusion criteria and exclusion criteria. Patients were randomly allocated into 4 groups. First group is only conventional CABG. Second is CABG with pulmonary vein isolation. Third, CABG with PVI and amiodarone administration after operation. Fourth, CABG plus amiodarone administration. To date, we have enrolled 174 patients totally. The baseline characteristics of patients in all of the group were similar. Here is some echo data. We will know significant differences. We have done the bipolar ablation before the main procedure. Study group were not different with respect to intraoperative characteristics. Here, the post-op complication measures, there were not statistically significant differences. We didn't observe cases of MACE in any groups after operation during in-hospital period. The incidence of POF in CABG PVI amiodarone group was significantly lower than in CABG alone group and in CABG amiodarone group. The incidence of POF in CABG PVI group was significantly lower than in CABG alone group and in CABG amiodarone group also. In hospital results, CABG PVI amiodarone group showed significantly lower time of ventilation as well as ICU length of stay. Freedom from AF up to 12 months in CABG PVI amiodarone group and CABG PVI group were significantly higher than in CABG alone group. Freedom from MACE up to 12 months had no statistical differences in all study groups. So, in conclude, the combination of prophylactic PVI and amiodarone administration revealed significant positive results in the prevention of new onset postoperative atrial fibrillation. This strategy may be used to prevent postoperative atrial fibrillation in higher-risk patients. Thank you for the attention.
Thank you very much. Any question from audience?
That's quite a controversial proposition to prophylactically isolate the pulmonary veins. I'm not sure that I could have passed that by my internal review board because the data, even if our goal is to reduce perioperative AF, it's true that that's quite a big step. In terms of adverse events, I assume you didn't have any particular issues with this.
No, we have good results, and of course, PVI and amiodarone group was better, and this strategy may be used in some high-risk patients for AF.
One thing that I am, let's say, somewhat surprised by is that your baseline group has a very high rate of perioperative AF, just 40%. That's we're used to having a lot of perioperative AF, but 40% is quite high.
Maybe we will include, maybe it's our fragile patients, maybe it's everyday practice, I don't know, but it's 30% every time we received post-op atrial fibrillation also.
Okay. Dr. Ad?
I agree with your comment, but it's something we need to pay attention because there is another prospective randomized study that was just finished and it's going to be published soon in Journal of Thoracic that actually showed even more impact of bilateral PVI as prophylactic without amiodarone. So I think it's something we need to pay attention Because we had the only study ever that we mapped patients with postoperative AFib, and it's the same AFib. So it's kind of a conundrum. So we'll see what's going on. I have one question. When you say PVI plus amiodarone treatment, is it prophylactic amiodarone, or you just started after surgery?
After surgery. After surgery, just after surgery in ICU department.
Okay, because I think the right control is the only comment. I think it's an excellent, preview to what's coming in the next few. Is actually taking the Papa Bear protocol with prophylactic amiodarone and compare it to PVI. And I think over there you may not find that you have such an advantage.
Maybe, Nif, maybe.
Yeah, excellent.
Thank you very much.
Thank you.
So I'll call Marco Gemelli back up to present how does a coronary endarterectomy look like at 3 and 6 months.
So, hello again. I'm going to present a case done in Lankenau Medical Center by Dr. Torregrossa, who is here. And basically, it's the presentation of a procedure of coronary endarterectomy with an angiographic follow-up, clinical and angiographic follow-up. So we all know that coronary endarterectomy represents an adjunctive tool for patients with diffuse calcific coronary artery disease. And its complexity, high surgical risk, and uncertain outcomes made this procedure very uncommon in cardiac surgery. So only few experienced surgeons publish data with good outcome. And in this presentation, we are going to describe the success of a coronary endarterectomy procedure in a very high-risk patient with excellent clinical and angiographic outcome. So a 71-year-old man was admitted in ED with a diagnosis of STEMI. This patient had a lot of comorbidities, and most important one was a severe insulin-dependent diabetes with severe peripheral vascular disease. He was amputated, bound to a wheelchair. He was a smoker with prior MI, hyperlipidemia, so a lot of comorbidities. So he had an echo which showed a reduction of the ejection fraction around 30% with an apical akinesis and anterolateral and inferior hypokinesis. At this point, he had an angiography which showed an LED severely calcified with approximal 90% diffuse stenosis, a mid-CTO, and faint bridging collaterals to the distal LAD. The ramus or a very proximal OM was a large vessel with severe proximal 80 to 9% stenosis. The circumference was a subsevere stenosis, and the RCA had a significant stenosis with a patent distal RCA stent. So this is the pre-op echo, which shows some akinesia of the apex and some hypokinesis. Here we can see the pre-op coronary angiography with the left system and also the right system. We can see the patent distal stent. And this is the ventriculography, which show a very stuck apex of the heart. So this patient, after being admitted and be diagnosed with this severe calcific coronary artery disease, had ongoing chest pain with all these profile. We decided to put a balloon on insertion. The patient underwent an our team discussion, and the risk of mortality was very high for a surgery, 9.5%, with a very high risk of morbidity or mortality according to the STS score. So what we discussed in our team was to offer a CABG via sternotomy and plan to execute an endarterectomy if needed on the LAD. So the patient underwent a CABG ×3 with full sternotomy. We had endoscopic vein harvesting for graft. We also thought about taking the radial, but it was not possible because the right radial was used for the angiography, and the left were a very dominant vessel with a very small ulnar vessel. Skeletonized LITA, which was also not that easy because the patient had a motorcycle accident and the LITA was very calcified in the proximal part inside the sternum. We did two venous grafts, one on the ramus and one on the PDI performed first, and at the end of the procedure, the proximal anastomosis was done in a piggyback setting with the proximal anastomosis of the vein to the PDA on the aorta and the SVG to the ramus on the hood of the SVG to the PDA. This is an image of the proximal anastomosis. As we can see, the system, the enclosed two, and we can see in the second image the piggyback. But the most important thing for this presentation is the LITA to LAD, which was performed off pump, and while we were approaching the LAD, it was obvious that an endarterectomy was required. So basically, this is the finish of the endarterectomy procedure. As you can see, we remove a 5 to 6 centimeter piece of plaque, basically. And after that, we were thinking to reconstruct the hood of the LITA with the mammary, but unfortunately, the mammary couldn't reach the end of the cut. So what we have done was to put a vein patch on the LITA and then to anastomose the LITA on the vein patch. So the intraoperative transit time flow Doppler was actually very good for the SVG and on the ramus and on the PDA, but talking about an endarterectomy with a CTO, a distal CTO, was also very good for the LITA on LAD because it was around 34 with a PI of 3. And there was no complication during surgery. So the patient was extubated and weaned from the balloon on day 1. He was weaned from inotropes in day 2, and he had an echo showing a normal LV in size with EF of 50% in day 6. And here we can see the echo. So this is the first angiographic follow-up, 7 days after the operation. We can see here how the flow is not that great after the patch. And basically, we were not very happy with the limited extension of the LAD flow after the endarterectomy. And also, it was evidence that the flow was pretty slow in the SVG patch to the LAD. And there was a small penetration of the septa. So we thought that there could be some clot or some thrombosis. So we put and we discharged the patient on DAPT plus warfarin for at least 6 months. After 6 months, the patient came back for a follow-up. He was doing very well clinically. He was home. He regained the mobility that he had before this event. Of course, he had a double amputation of the feet, so the mobility that he can't have. And he was also put on optimized medical therapy, including Entresto and small dose diuretics. So we had an angiographic follow-up at 6 months that I'm going to show. And we can see that despite not being, of course, a normal coronary, but we can see that the flow is a little bit better in the distal LAD, and we can see also a small septal who is growing from the beginning of the vein patch. So basically, our consideration where there was a slightly improved flow via the SVG patch to a septal. There was, of course, the 2 veins where also I didn't show the image, but the 2 veins were injected and they were both open. And also we had some consideration to do because we saw that the vein patch probably was too big to give a very good distal flow, or we should have tried to reach the end of the anastomosis with the LITA to make a total arterial revascularization for the LAD.
I'm sorry to cut you off a little bit. We're already 3 minutes over time for your presentation.
Yeah, so
do you think we can go to the...
It's the end. Thank you. I was at the end.
Thank you very much. We have time for one very short comment, if ever there is one. If that is not the case, I think it's very interesting to see what these endarterectomies look like. It's true that we have to do them in some patients, but we don't really know what they actually give on angiogram. So, thank you.
Thank you.
So next speaker different in transit time flow measurement between arterial and venous graft for coronary artery bypass grafting in Vietnam population. Dr. J. Nielsen panel.
Actually, it's Dr. Tseng. Elaine Tseng.
Thank you. This is the work of our students, and so unfortunately they couldn't be here today. Basically, transit time flow measurements, or TTFM, is a quality control measure in CABG to look at intraoperative assessment of graft patency. It's reproducible. It doesn't take too much time, and it allows us to look at mean graft flow and pulsatility index, diastolic filling backflow, and assess graft failure. And so this is actually a preliminary study as we were starting to use TTFM to look at the differences between arterial and venous grafts in a veteran population. So as I said, it's a preliminary study. This actually starts with 58 consecutive veterans in 2021 from CABG and SAVR CABG patients. These looked at the TTFM measurements after protamine, and we looked at the IMA grafts compared to the non-IMA grafts. So this is kind of the breakdown of the patients. The vast majority of the patients were CABG times 3, 71%, but we did have a few that were CABG times 1 and CABG times 2. The graft characteristics, primarily the lima was used, but approximately 30% of the time the rima was used, and about 2/3 of the time the radial was used. So therefore, for BIMA, it was approximately 30%, lima plus radial was 64%, and 2021 was our transition from dual arterial CABG, which we had been doing routinely since 2013, and then starting in 21, we were moving towards multi-arterial grafting and all-arterial grafting. So this gives you an example of, for CABG times 1, what you see for lima to LAD for mean flow and PI. And then for CABG times 2, most of these were limas to LADs. There was a few where the lima went to the OM, and then the rima was used for the LAD. In about 1/3 of the patients, we used a rima, and most of those actually went to the OM or the ramus. 50% of the time we used the radial, of which 1/3 of the time it went to the right territory, and the remaining were for vein grafts. And so then this shows us the examples of how we broke it down for CABG times 3. Again, lima to LAD being the most common, occasionally doing the rima to LAD. When we did use the rima, which was about 37% of the time, it mostly went to the obtuse marginal, but with a few going to either the right or the LAD territory. Radials encompassed about 73%, and most of those were to the OM. And the vein grafts were also about 3/4, but split between the right and the OM. So if we look at the actual flow rates, when we take the percentage of grafts that were done out of all of those, then about 46% were IMA. And notably that the mean flow rates were similar between the lima and the rima, as well as the radials and the saphenous vein. However, for the IMA grafts, the flow rates were significantly lower than the non-IMA grafts, and most likely that's just the fact that you need to give the IMAs time to mature. And then when you look at it in terms of the target vessel flow rates, so if you look at LAD, again, mostly using lima, the right mostly using either vein or a little bit of lima, and then similarly for the OMs, it's kind of split between radial, vein, and then a smaller percentage of lima and rima. But when you look at the actual flow rates, interestingly, the mean lima flow was significantly lower than the rima flow when specifically targeted to the LAD. And so we'll have to see that as we look. As I said, this is a preliminary part from when we did it in 2021. So now that we've gone to 2023, we'll have to see in our larger subset if this still holds true. But there were no significant differences in other target vessel mean flows when comparing between the graft types. When you look at pulsatility index, there was no significant difference between the IMA and the non-IMA grafts. And there was also no significant difference between the lima and the rima. However, the radial had a PI that was significantly lower than the vein. And so when you look at that in subset analysis, the radial was significantly lower, particularly in the OM target. And this I explain as just being sort of a patient selection and target selection. So if the patient has a 90% lesion, then we're more likely to use a radial, whereas if they have a lower percentage stenosis, we're more likely to use vein. And so when you are going to have more competitive flow, you're also going to have a higher PI. So in conclusion, we found a significant difference in mean flow rates between the IMA and the non-IMA grafts. As the IMAs take time to mature, there was a significant difference in flow rates between the LIMA and the RIMA to the LAD, but there weren't significant differences between grafts to all the other target vessels. We had no significant differences in mean PI between the IMAs and the non-IMAs, or the LIMA and RIMA, but between the radials and vein grafts based upon the choice of the stenosis of the targets. And therefore, we found that significant difference primarily in the radials and the vein grafts to the OM, but no significant differences to the other target vessels. Thank you.
Thank you very much. Any comment? Okay.
Thank you very much. I think we'll move on due to time. And I'll call the next presenter, Dr. Patel, who will talk to us about a novel proximal sealing system for multiple aortic anastomosis.
So my disclosure, I'm on a scientific advisory board for the VGS solution. So we present our initial experience with the Viola anastomotic device. Obviously, we all know, and Gianluca Torregosa mentioned about the side-biting clamp. It can cause known neurological events. It can also cause embolic issues with kidneys and also increases length of stay because of these comorbidities and complications. So this is essentially the Viola anastomotic device. It comes in two parts, which is the device itself. The punch is integrated into the cable, but the punch needs to be attached to, there's a punch handle which needs to be attached after the device is enrolled. So basically, device is a 19-hole with a frame like an umbrella. This is the introducer. Once you fold this like an umbrella inside this sheath, and that sheath is introduced, and then there's a boundary marker which sort of acts as a guide, and you can put that sort of a stencil onto the aorta and put marking. I personally don't use it because it's quite obvious. You can see so that you don't puncture the seal of or the diaphragm of that. So once the Viola devices comes on this handle, what you do is you put the punch handle and connect it to this point and use heparinized saline and just open and close the umbrella or the seal a few times. Also examine for the integrity of the device and then get it ready to be deployed. The system works by putting a 14-gauge needle. You make a small hole, introduce the system, and then deploy the device and apply traction. And at this time, give it to the assistant, keep it vertical. You engage the punch, and then create the punch. So this is an advantage of this device over, say, competition heartstring, is that you are deploying the device first before you make the punch so there is no bleeding. Then you make sure that the core of the punch is good, and the punch is, again, engaged onto the handle, and with a gentle traction, you attach the cable, and then you have a completely bloodless field to construct the anastomosis. Hold the needle in the middle, obviously, so that you don't perforate the diaphragm. And then avoid very light tension on the string if you want to make it more. And as you can see over here, you don't need a blower mister. You just have a coronary sucker from time to time. Very hemostatic, excellent dry seal. We leave last 2 or 3 sutures loose to retrieve the device. After a couple of first tries, what we did was we leave one stitch. We don't put the last stitch and remove the device and then put the last stitch. So this is sort of learning curve, and this anastomosis is pretty straightforward. Then once you have finished the anastomosis, you push it towards the arch, fold the device inside. There's just a little bit of blood loss at this time, and then you pull the device out, put your finger there, and then tie the suture. So I've personally done now 8 patients, but we have had 6 patients. Most of them had more than 2. And as you can see, sheath insertion, I would say out of 5, the first case, I did not clear off the adventitia. I just put the needle and hoped to put it in, and then there was a little bit of difficulty getting it through the friction. Nevaj suggested we should clear the adventitia. After that, it was pretty good. Connecting and disconnecting puncture can be a little clutchy, but then we figured it out. And then visibility during suturing, as you can see, the patient number 5, I was allowing my fellow to do it, and he put the needle through the diaphragm, and then there can be blood loss and you could have issues. But otherwise, an ease of device retrieval, the first one, we left a few sutures loose. After that, you bring it towards the toe where you end the anastomosis and then just pull it out. So we evaluated this device in 6 patients, simple to operate, excellent sealing. On an average, we did 2 anastomosis per patient using a single system. I did 1 case with 3, and it's quite easy to do that. It's safe with minimal perioperative bleeding in the anastomosis area. Thank you.
Thank you very much. I think we're running over time, so if you have any questions, I would invite you to talk with Dr. Patel afterwards. Certainly a very interesting device. And our last presentation, Dr. Heng will talk about surgical unroofing of myocardial bridges.
Hi, good afternoon. My name is Albert Heng. I am a cardiothoracic surgery resident at Stanford, and it's my privilege to present to you today on our institutional experience with the surgical unroofing of myocardial bridges. We have no disclosures. So myocardial bridging is a congenital coronary anomaly that occurs when a coronary artery courses through the heart muscle for a short distance, forming a bridge of overlying contractile myocardium. This is most commonly observed in the LAD, and although the true prevalence is not accurately known, myocardial bridging is estimated to be present in up to 1 in 3 people. For most patients, systolic compression of the LAD caused by the bridge is benign, owing to diastolic coronary blood flow. However, some patients will go on to develop symptoms of angina, both typical and atypical. There have been a few case reports of sudden cardiac death where the only abnormality detected on autopsy was that of a myocardial bridge. And the proposed mechanism for this is delayed diastolic relaxation following systolic compression, thereby leading to impaired diastolic coronary perfusion. The first-line treatment for patients with symptomatic myocardial bridges is medical management, and careful testing is needed to identify the subset of those who stand to benefit from surgical unroofing following failure of medical management. Our institutional practice has followed a paradigm of initial stress echo and coronary CTA, followed by first-line medical management. Patients refractory to medical therapy then proceed to invasive hemodynamic testing, and those with hemodynamically significant bridges, indicated by a diastolic fractional flow reserve of 0.76 or less, are determined to be candidates for surgical unroofing. This is an example of a coronary CTA in a patient demonstrating the course of the coronary arteries. We can use this to characterize the length, thickness, and coverage of the myocardial bridge. Here in this example, the bridge was measured to be 24 millimeters in length with full encasement within the overlying muscle. With a confirmed diagnosis of myocardial bridge, cardiac catheterization can be used to rule out the presence of other CAD. Here you can see the classic milking sign representing compression of the affected LAD segment during systole. A dopamine challenge during catheterization is used to calculate the diastolic FFR, which in this case shown here was significant at 0.57. During catheterization, the bridge is also further characterized with the use of intravascular ultrasound. Here the presence of the bridge is again confirmed with a halo sign that you can see around the affected segment. The degree of LAD compression is determined to be 49% during systole, with an associated proximal plaque burden of 25%. Information from IVUS is then mapped onto the angiogram. The length of the bridge is again confirmed to be 24 millimeters, and is located 27 millimeters from the LAD circumflex bifurcation. You can also see in this image that there are 3 septal branches that are jailed within this bridge. So once mapping is complete, the surgical technique of unroofing involves division of the epicardium overlying the LAD with a beaver blade, after which the surgical plane of dissection is extended in a distal to proximal direction with tenotomy scissors. Venous bleeding is controlled with a combination of cautery and clips, and on completion, the length of the unroofed artery is measured to confirm concordance with preoperative imaging. At our institution, the surgical approach is tailored to patient disease and anatomy. Off-pump mini thoracotomy is preferred for single myocardial bridges less than 4.5 centimeters in length, located at least 2.5 centimeters away from the circumflex. Off-pump sternotomy is utilized for presence of 2 or more bridges or long segment bridges. Finally, cardiopulmonary bypass and sternotomy is utilized in cases of myocardial bridge located in proximity to the circumflex or those with LAD coursing through the RV. Over the past decade, we have seen a progressive rise in the annual frequency of surgical myocardial bridge unroofing, with a total of 199 adult patients undergoing surgical unroofing of hemodynamically significant myocardial bridges. With evolving practice, off-pump unroofing via mini thoracotomy or sternotomy has become the preferred approach at our institution. Among 199 adult patients, unroofing was performed via off-pump mini thoracotomy in 44 patients, off-pump sternotomy in 88 patients, and sternotomy on pump in 67 patients. The clinical characteristics of this patient population is notable for their younger age and lower rates of metabolic syndrome as compared to the traditional CAD and CABG population. Hypertension, hyperlipidemia, and diabetes were all present in less than 50% of all patients, and approximately 40% of patients had no history of any hypertension, hyperlipidemia, or diabetes. Following unroofing, hospital outcomes demonstrate a high profile of safety with no deaths or major complications occurring in any patient. And as compared to myocardial bridge unroofing on cardiopulmonary bypass, patients undergoing off-pump unroofing had shorter total duration of postoperative ventilation, shorter ICU length of stay, and shorter postoperative length of stay. 6 months after surgery, patients were followed and assessed with the Seattle Angina Questionnaire, measuring physical limitation, anginal stability, anginal frequency, treatment satisfaction, and quality of life. And significant improvements in all 5 categories were seen with every surgical approach, that is on-pump sternotomy, off-pump sternotomy, and off-pump mini thoracotomy. In conclusion, the surgical unroofing of myocardial bridges can be safely and effectively performed in a select patient population with hemodynamically significant disease. Surgical approaches to unroofing can be tailored to patient anatomy, with resulting improvements in angina, functional status, and quality of life, and long-term outcomes remain to be seen. I would like to thank my mentor, Dr. Jack Boyd, and the Congress for the privilege of floor.
Well, thank you very much. I believe we've run over our time, and our main session is already ongoing in the plenary. So thank you very much for an outstanding session where we learned about robotic CABG, on and off pump CABG, atrial fibrillation management, even prophylactic management, coronary endarterectomy off pump, TTFM, new devices for proximal anastomosis. And are Viola around here? Can we go talk with them also? So that'll definitely be something I'll be interested in. As well as how to manage myocardial bridges. So thank you very much.